same. Once you let it change. It's like a family tree, part of you and part of me. And if we should separate, go your own way, I won't wait.
Bring the funk back. Bring the funk back.
Aku Ati. Mengandung kali ni rasa lain. Rasa letih, lesu. Hari ni aku ada temu janji di klinik. Doktor kata nak bincang pasal keputusan darah. Doktor sahkan aku ada diabetes. Apa silap aku? Rupa-rupanya selama ni aku makan dengan cara yang tak betul. Dan diet yang tak seimbang. Demi kesihatan aku dan anak aku kena berubah. Oh, baru aku tahu banyak rupanya fasiliti kesihatan disediakan untuk pemeriksaan kesihatan ibu mengandung. Kata doktor, sebagai ibu mengandung, aku layak untuk mendapatkan perkhidmatan kesihatan secara percuma. Tidak terkecuali, ibu mengandung pun perlu membuat pemeriksaan gigi dan mulut. Rawatan akan diberikan jika perlu. Jangan risau, tak sakit pun. Dengan nasihat doktor, aku mula buat perubahan. Hanya dengan senaman ringan, buat bersama teman, senaman terasa mudah. Kalau dulu, aku suka makanan ringan, tapi tidak kali ini. Semuanya tidak mustahil sekiranya kita memanfaatkan segala perkhidmatan kesihatan yang disediakan. Kita semua boleh memilih untuk sihat. Kalau saya boleh, kenapa tidak anda? Dapatkan pemeriksaan kesihatan di klinik yang berdekatan.
Masyarakat kumpulan etnik minoriti yang terpinggir lebih cenderung untuk tertinggal dalam menerima perkhidmatan kesihatan. Tiada siapa yang patut ditinggalkan.
Jurang perbezaan sosioekonomi yang tinggi menyebabkan golongan ini berada jauh pada tahap yang rendah, lebih rentan dengan sakit, jatuh dan rebah. menjadi punca tiada pendapatan kerana tidak sihat dan lelah. Tiada siapa yang patut ditinggalkan. Tetapi untuk mereka, halangan ini adalah rintangan yang tidak kelihatan. Tembok panjang yang menyukarkan, pagar benteng yang tidak diperlukan untuk mereka mendapatkan perkhidmatan kesihatan.
Ini bermaksud akibat jurang perbezaan sosioekonomi, golongan ini mempunyai jangka hayat yang lebih pendek dan tahap kesihatan yang lebih rendah. Tiada siapa yang patut ditinggalkan. Tanpa bantuan, seolah-olah mereka telah pun ditinggalkan.
Apa yang kita lihat tidak semestinya sama dengan apa yang mereka rasa. Orang yang tidak kelihatan seperti anda sebenarnya adalah orang yang sama seperti anda. Orang yang tidak berfikiran seperti anda sebenarnya adalah orang yang sama seperti anda. Orang yang tidak bertindak seperti anda sebenarnya adalah orang yang sama seperti anda. Tiada siapa yang patut ditinggalkan kerana kita adalah sama.
Perbezaan adalah sesuatu yang perlu diraikan menjadi punca perpaduan dengan kesihatan bersama-sama dengan satu sasaran. Marilah kita berdampingan pada landasan yang benar untuk kesihatan bersama yang lebih baik, kerana tiada siapa yang patut ditinggalkan.
Bagi bernama radio, anda sudah bersama dengan Dr. Nurul Fahiza Fahimi yang merupakan pelajar pasca siswaza doktor dalam kesihatan pergigian awam dari UiTM.
Juga untuk mereka dapatkan maklumat berkaitan dengan Smile 3.0 tu ada laman sesawang dan sebagainya.
Ya betul, kita ada laman web kita lah www.smile.itm.com.
InsyaAllah, dan kita bersama-sama dengan Dr. Nurliana Roslan selaku pelajar pasca siswaza Doktor Kesihatan Awam Pergigian UiTM Sungai Buloh. Ada lain seperti lidah, melangit, gusi dan juga tisu-tisu lembut.
kita nak share resipi sihat. Cap, 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 capcay. Mula kita potong bawang, carrot, then kita potong mushroom, then kucai, and ayam. So, kita rebus suun. Kita stir fry bayam tadi dengan carrot and then mushroom, and then kita stir fry juga bawang and kucai, dan kita goreng sedikit ayam tadi and then telur, dan kita hiris-hiris telur tadi, dan kita nak bancuh sos dia dengan kicap, minyak bijan dan juga sedikit garam. Ini kacau-kacau-kacau. Dan kita nak susun semua bahan tadi sebelum kita gaulkan dia. Ini sihat tau korang. Okay, lepas tu kita taburkan sedikit sesame seed. Ini kita gaulkan semua. Dah siap.
No matter who you are, no matter where you come from, there is no big deal for us walking forward together. No matter when you know, no matter what is your pulse, there is way to go for us loving to all the people around the world. Sharing your experience that make the whole world smile by your kindness and talent, and sharing your commitment to help the whole world smile by your passion and intention. Lend us a hand. No matter who you are, no matter where you come from, there is no big deal for us walking forward together. No matter when you know, no matter what is your pulse, there is way to go for us loving to all the people around the world. Sharing your experience that make the whole world smile by your kindness and talent, and sharing your commitment to help the whole world smile by your passion and intention. Lend us a hand. Sharing your experience that make the whole world smile by your kindness and talent, and sharing your commitment to help the whole world smile by your passion and intention. Sharing your experience that make the whole world smile by your kindness and talent, and sharing your commitment to help the whole world smile by your passion and intention. Sharing your experience that make the whole world smile by your kindness and talent, and sharing your commitment to help the whole world smile by your passion and intention. Lend us a hand. By your passion and intention, lend us a hand. Come to join with us, ICD, give us your hands.
The International College of Dentists is the oldest and largest international honour society for dentists in the world. Established in 1928, the college has more than 12,000 members in 122 countries who've been awarded the prestigious title of Fellow in the ICD. Our motto is recognising service and the opportunity to serve. ICD aims to achieve 5 goals following the 5 college core values to which they're linked: leadership, recognition, humanitarianism, education, and professional relations. Leadership: to uphold the highest standard of professional competence and personal ethics. Recognition: to recognise distinguished service to the profession and the public worldwide. Humanitarianism: to foster measures for the prevention and treatment of oral disease by encouraging and supporting humanitarian projects. Education: to contribute to the advancement of the profession of dentistry by offering the growth and diffusion of dental knowledge worldwide. Professional relations: provide a universal forum for the cultivation of cordial relations within the profession and to assist in preserving the highest perception of the profession. The Office of the International Council is the world headquarters for the ICD, located in Flint, Michigan, USA. The Council office conducts the daily business and affairs of the college and is representative of the International Council. The International Council is ICD's signature institution and umbrella organisation for the worldwide membership and sections. There are 40 members of the Council, including the international officers and councillors who represent ICD's sections and regions in 122 countries around the world. ICD constitutes 15 autonomous sections to facilitate administration at local and regional levels and to promote more effectively the aims and objectives of the college. There are currently 11 regions within Section 20 Asia sector that cover 16 countries. The number of countries under Section 20 Asia sector is expanding, and we've significantly grown in the number of new members over the past year. In Section 20 Asia, there are 7 categories of membership with different requirements for each of the categories: Emeritus Fellow, Master Fellow with outstanding contribution, Master Fellow, Honorary Fellow with outstanding contribution, Honorary Fellow, Fellow with outstanding contribution, Fellow for a member with at least 5 years clinical experience who has delivered significant contribution, Honorary Member, Member or Elite who has served the ICD with distinction, Member for registered dentists, young dentists with less than 5 years clinical experience, Elite, non-dental profession member, Student for undergraduate students. Fellowship in the college is extended by invitation only. A nominated dentist or member of the society must pass a rigorous peer review process leading to the recognition of the individual's outstanding professional achievement, meritorious
It's like a family tree, part of you and part of me. And if we should separate, go your own way, I won't wait.
Bring the funk back. funk back.
Aku Ati. Mengandung kali ni rasa lain. Rasa letih, lesu. Hari ni aku ada temu janji di klinik. Doktor kata nak bincang pasal keputusan darah. Doktor sahkan aku ada diabetes. Apa silap aku? Rupa-rupanya selama ni aku makan dengan cara yang tak betul. Dan diet yang tak seimbang. Demi kesihatan aku dan anak aku kena berubah. Oh, baru aku tahu banyak rupanya fasiliti kesihatan disediakan untuk pemeriksaan kesihatan ibu mengandung. Kata doktor, sebagai ibu mengandung, aku layak untuk mendapatkan perkhidmatan kesihatan secara percuma. Tidak terkecuali ibu mengandung pun perlu membuat pemeriksaan gigi dan mulut. Rawatan akan diberikan jika perlu. Jangan risau, tak sakit pun. Dengan nasihat doktor, aku mula buat perubahan. Hanya dengan senaman ringan, buat bersama teman, senaman terasa mudah. Kalau dulu, aku suka makanan ringan, tapi tidak kali ini. Semuanya tidak mustahil sekiranya kita memanfaatkan segala perkhidmatan kesihatan yang disediakan. Kita semua boleh memilih untuk sihat. Kalau saya boleh, kenapa tidak anda? Dapatkan pemeriksaan kesihatan di klinik yang berdekatan.
Masyarakat kumpulan etnik minoriti yang terpinggir lebih cenderung untuk tertinggal dalam menerima perkhidmatan kesihatan. Tiada siapa yang patut ditinggalkan.
Jurang perbezaan sosioekonomi yang tinggi menyebabkan golongan ini berada jauh pada tahap yang rendah, lebih rentan dengan sakit, jatuh dan rebah, menjadi punca tiada pendapatan kerana tidak sihat dan lelah. Tiada siapa yang patut ditinggalkan. Tetapi untuk mereka, halangan ini adalah rintangan yang tidak kelihatan. Tembok panjang yang menyukarkan, pagar benteng yang tidak diperlukan untuk mereka mendapat fikiran seperti anda.
Assalamualaikum and a very good morning to everyone here with us on YouTube live streaming. Welcome to the Smile UiTM webinar series, which is brought to you by the Faculty of Dentistry, University Technology Mara. For those who are only joining us today for the first time, SMILE is an acronym for the words Selamat, Masyarakat, Ideal, Lancar and Equity, which represents the aspirations for our oral healthcare service, which is to have a service which is safe for the community, running smoothly at an optimum and ideal capacity whilst promoting equitability. This year's SMILE program is dedicated to promoting dental inclusivity and universal health coverage for the Malaysian population. The SMILE campaign, which consists of an outreach program, a series of webinars, a comprehensive website on pertinent information surrounding the topic of health inclusivity, and a few mobile apps developed towards the same aim, is a campaign organized in collaboration with our 9 strategic partners and collaborators who are the Kementerian Pendidikan Malaysia, Yayasan Muhammad Noah, Jabatan Kemajuan Orang Asli, Pejabat Kesihatan Daerah Keluang, the International College of Dentists Region 33, Persatuan Pakar Pergigian Kesihatan Awam Malaysia, the Malaysian Dental Association, the Dental Students Association, and Persatuan Juruterapi Pergigian Malaysia. Now, before we proceed further, please allow me to introduce myself. My name is Dr. Budi Aslini Muhammad Sabri, and I am a dental public health specialist and a lecturer in the Faculty of Dentistry, University Technology Mara. And today it is my privilege to host this morning's forum about a very important and timely topic that has a big impact on individual health and also the wealth of the country. And the topic for today is healthcare inclusivity, the economic impacts. Now, before we proceed further, allow me to give out a few housekeeping announcements. Should you have any burning issues you'd like the panelists to discuss or address, kindly type in your questions or requests in the chat box and it will be relayed to the panelists. The program evaluation link and attendance link will be shared at the end of this session via the YouTube chat box, and certificates of participation will be emailed to you within 5 to 10 days after this webinar. Now, finally, I'm very pleased to welcome our 2 distinguished panelists who are in fact titans in the fields of development, program policy, public health and health economics to share their thoughts, expertise and insights regarding the issue at hand. Now, our first panelist is Prof. Datuk Dr. Syed Muhammad Al-Junaid. Professor Emeritus Datuk Dr. Syed Muhammad Al-Junaid specialized in public health medicine and was the first Malaysian to obtain a PhD in health economics from the London School of Hygiene and Tropical Medicine in 1995. He obtained his MD from the National University of Malaysia and a Masters of Science in Public Health from the National University of Singapore. He was the founding head of the International Centre for Case Mix and Clinical Coding, which is a centre of excellence on case mix and health economics research in the Faculty of Medicine UKM, which was established in 2011. He is appointed as a Professor of Community Medicine at the International Medical University Kuala Lumpur, and prior to that, he served as a Senior Research Fellow of United Nations University International Institute for Global Health from the year 2006 to 2014. He was also the founding professor and served as the Deputy Dean of Research and Postgraduate in the Faculty of Public Health, Kuwait University. So welcome, Prof. Datuk Dr. Syed Muhammad Al-Junaid. Now, our second panelist is Mr. Azrul Muhammad Khalid. Mr. Azrul has more than 21 years of experience as a development and program policy professional and has a genetics and public health policy background. He has experience working with the Institute for Democracy and Economic Affairs, the International Planned Parenthood Federation, UNAIDS under the UNDP and the ICRC. Mr. Azrul has also worked with UNICEF and Malaysian AIDS Council. He is currently the founder and chief executive officer of the Galen Centre for Health and Social Policy, an independent public policy research and advocacy organisation based in Kuala Lumpur, Malaysia. It is a non-party think tank prompting a health and social care vision based on accountability, transparency, and the public interest. He is the co-founder of the Code Blue, which is a health news website. And Mr. Azrul is also a board member of the Centre to Combat Corruption and Cronyism, He is a writer. He has been a columnist with 2 Malaysian media outlets and is a co-presenter with BFM's Health and Living program, where he discusses health policy. So welcome, Mr. Azrul. Thank you for being with us today. Okay, so ladies and gentlemen, as we all know, healthcare is important for people's health and also the economy. It is one of the most important things that help countries grow and progress. However, despite progress in medical advancements and access to care, various economic challenges continue to impact healthcare providers in the delivery of care. So, for today's forum, I think it's fair to start off with sort of an overview on health economics. So, Prof. Dato, as an expert in health economics, could you kickstart this forum by defining for us what is health economics, and could you explain to us the relationship between health and economics?
Yeah. Thank you, Madam Chairperson, and very good welcome to everyone who joined this webinar. Your question that you posed to me is regarding the definition of economics. So if you compare economics with medical services and also medicine discipline itself, medicine has been going on maybe 500 years BC, whereas economic as a discipline is quite new. Only in the middle of the 18th century that the discipline of economics was actually created through someone who actually a professor of at that time called moral philosophy, who tried to actually describe what is going on at the marketplace in terms of human resource activities and also all other things related to the various players in the marketplace. And Professor Adam Smith is the first person to actually describe this through his books, which is still valid until today. We call it Wealth of the Nation. And in this book, he tried to explain the different forces that control players in the economic sector. So, however, the real definition of economics has been proposed by many researchers. I think one of the most famous definition of economic is Professor Samuelson from US. And he was actually the Nobel laureate winner in middle 1980s, I think in 1984. And he defined economics as a study on how men and also society choose to deploy scarce resources, either money or non-monetary kind of resources, in order to actually produce services and produce goods that can be consumed now and also in the future. So under his definition, Professor from US that actually defined this, Samuelson actually touched on very important aspect of what we call scarcity. When we have resources which are limited in volumes and also in terms of the amount, then the use of these resources has to be very done carefully in order not to jeopardize other things that need the resources as well. So whenever there's a scarcity in resources, economics studies came in order to make sure that we have a good justification to actually distribute the resources. As you know, in healthcare, resources are always limited. We don't have much financial resources. We are spending probably about 3 to 4% of our GDP on healthcare compared to other sectors like education, other sectors like defense, for example, where they spend much more. Secondly, when we also have to remember that in economic, we have a terminology what we call opportunity cost, which means that whenever we spend the scarce resources, we cannot use the same resources to produce or to actually produce another services. So once you actually utilize these services for a particular product, then you have to sacrifice other things that you cannot produce. So, for example, if a good example is we spend on, say, for example, buying aeroplanes or buying military equipment, we cannot use these resources to build hospital or to build clinics. So these are the opportunity costs, the cost of sacrifices. So economists actually are very concerned about this. whenever you spend certain resources, it means that you are sacrificing other important services that may be required in order for our economy or our health system to function. So in short, that is how what is meant by economics. And when we apply the economics principle to healthcare, and this is what we call health economics. And health economics is actually mainly concerned about how we allocate different resources within healthcare, and how do we differentiate, how do we actually allocate these resources between two big areas in healthcare, which is the preventive and curative services. Which means that if you spend a lot on curative services, then there will be little less for the preventive services. As we know that preventive services is very important. It actually have an impact on long term, whereas curative services is very costly, but the impact is short term. So how do we actually balance this? In Malaysia, for example, we are spending probably about less than 30%, maybe about 20 to 25% on preventive services. We spend nearly about 70% in curative services, treating patients who are already at the late stage of diabetes, for example, patients who have got stroke as a result of poorly controlled hypertension. If we put a lot more resources on preventive services, this may not happen, and we would be able to actually save more life at a lower cost. So this is the important concept that we have to understand. I think I'll stop here, Dr. Budi.
All right. Thank you very much, Prof. Dato. I think that was a very good overview of the definition of health economics. And I totally agree with the definition of how health economics is actually a study looking at the scarcity of resources and the concept of competing interests. And when we talk about competing interests in terms of health economics, it's not only between other sectors, the competing interests of health and other sectors, but also within healthcare itself, between different sections of healthcare and between preventive and curative. Like I myself, as a dental public health, I think one of the issues we have, the challenges, even within our faculty in terms of allocation of resources towards promoting preventive care is always a struggle between providing advanced medical care. But I think we'll go into that a bit later, talking about the impact of prioritizing between different sectors within healthcare itself. So moving on, maybe Mr. Azrul, I'd like to ask, maybe you can elaborate a bit on what are the key economic challenges facing healthcare providers today, and how are they impacting the delivery of care?
Well, there are quite a number of different challenges that face a healthcare system in any country, and that includes Malaysia. And one which is a very simple one, which is the economy itself. Today, if you were to look at an ongoing situation with regards to the Malaysian ringgit against the US dollar, right now we are facing a tremendous challenge because the value of the US dollar has increased significantly against the ringgit, which means that today the value of the ringgit is much less. Now, if taken in isolation, it may mean nothing much for healthcare or the delivery of services. But when you take it within context, it's a huge factor, because today, as a result of this recent development, healthcare, or the cost of providing healthcare, has become more expensive here in Malaysia. And the reason why is simply because a lot of the transactions that we conduct in terms of the purchasing of or importation, procurement of a lot of the specialized products, goods and so forth, is conducted in the US dollar. And a lot of that is brought in from abroad. Not everything is done here in Malaysia. It's not everything in terms of the kinds of needs for a modern healthcare system is able to be provided for by its domestic market. So a lot of it needs to be imported. So something as simple as the value of the dollar against the ringgit can mean that it will have a direct impact on not just the quality of treatment and care and services that are able to be provided, but also in terms of coverage. Meaning today, if this continues on, you could actually result in a shrinking of those very same services that we depend on as part of universal healthcare coverage that Malaysia provides. We talk a lot in public health about the social determinants of health, but what we don't talk about often is the commercial determinants of health, which is something that has become more and more not only just apparent, but also dominating the conversation. I think we've seen within the context of the recent COVID-19 crisis, where there was a fair amount of dependency upon the availability of ventilators, for example, in which countries would actually fight for the scarcity, for the scarce resources that were available. And there were circumstances in which you would find that countries were bidding each other in warehouses and airport hangars to get the kind of equipment that was needed for that COVID crisis management. And so this is the same also for what happened during the vaccines phase as well, where you find that a lot of countries that had a much more stronger capacity to be able to provide and pay for the vaccines a lot earlier managed to get their vaccine stocks a lot earlier and therefore able to provide for their populations. So there are a lot of factors that come into play when it comes to the ability for us to provide healthcare. And it's a very interesting conversation that's going on, I think, in social media right now, where you can find in the Twitter Jaya space, there is a huge controversy that's happening with regards to a conversation concerning the RM1 and RM5 fee or the user fees that are being paid by patients when accessing public healthcare. And the conversation there is basically, does this represent the value of the healthcare practitioner service? Or does this also mean that this is the value of our healthcare service? So even the appreciation of the public itself in terms of how much it pays in user fees also affects how a healthcare system is able to be supported, not just in terms of the financial perspective, but also in terms of how the public also regards and appreciates that service. So the complexities of a modern healthcare system are many. And unfortunately, when it comes to Malaysia, we are still very much wrapped up in conversations of how to reform our healthcare financing system. And this is something that unfortunately is a 30-year conversation that seems to not end. And that actually is important for us to be able to future-proof our healthcare system, not just to meet the challenges of today, but also for the many years to come. And unfortunately, when it comes down to it, we seem to not take a realistic view on how to support and maintain the sustainability of the healthcare system. And that all goes back down to what we understand are the determinants of that healthcare system. So the economy is just one aspect, but it certainly is a major component for which the healthcare system depends on a realistic view. So, you can see what's happening in other countries, in Indonesia, Philippines, Thailand, all of which have had to introduce reforms and innovation in order for it to be able to deal with the economic factors of health, which are increasingly more pressing, but also large. I think Prof. Syed just now mentioned about the defense budget that sometimes in other countries they spend a lot more when compared to other countries. Like the US, I think, spends on defense larger than the defense budgets of at least, I think, 11 countries after that. So their defense budget is quite significant. And unfortunately, when you look at how Malaysia spends on its defense budget, it's not comparable. Malaysia's defense budget is much, much smaller than its its rivals in the region, especially when you consider the fact that half of what Malaysia spends on healthcare is spent on defense. So you find that it's not necessarily possible to move money from one side of the budget to the other side of the budget, or reduce the defense expenditure to fund health. So what we need to actually have a conversation really today is, how do we find new sources of funding to address the increasingly complex but also newer economic determinants of health. And this is something that is an ongoing conversation, and people at ProfSite are actually at the forefront of those discussions, not just in Malaysia but in other countries as well. So I think I'll stop there and I'll hand it back to you.
All right. Thank you, Mr. Azrul. Actually, if you don't mind, I'd like to, I have a follow-up question in regards to what you mentioned, the commercial determinants. I think that is quite an interesting concept. Commercial determinants of health. You are right to say that you're very familiar with social determinants, and somehow the commercial determinants can sort of get overlooked. Especially to the general public. But when talking about commercial determinants in Malaysia specifically, do we have any sort of regulation or policy in place to sort of regulate the commercial determinants, such as market regulation or regulations on patent, things that are in place in the system to actually help drive the costs down, or to sort of at least stop it from escalating?
Well, if I were to be honest, and an economist would be in a better position to actually speak to this topic, I don't believe the economy or the market as it is understood in countries like Malaysia, where essentially, though we like to say or deny it, we actually have a free market. The intention of the system is not to drive down costs, really. It's to basically be able to get the best possible value for whatever is being purchased. And in a free market where there is competition between those providers of services, goods, and so forth, the argument is that when there is adequate competition and there is choice to be made for the consumer, therefore the consumer would be able to benefit from looking at that selection of choices and decide what would be the best value for money that they can get for the amount that they spend. And so it may not necessarily mean that the cost will be lower. It could mean that, for example, you would be willing to pay a little bit more if you can ensure that the quality of service that you get is better. So if you look in terms of pharmaceuticals, and this is a hot topic sometimes, because in many countries the price of drugs is something that is not only a regional debate but also an international one, with patents being thrown in and so forth. The question really is does a cheap drug automatically mean that it is a good drug? Or if it is cheap, does it mean that the quality is more inferior compared to, say, a drug that you pay more for? Does a generic drug, which could significantly cost less, be of inferior quality compared to a innovative or branded drug, which you probably have to pay a lot more? So you would actually look at these factors and sometimes decide, even as a patient or a consumer yourself, on how you make decisions based on those factors. But as a country, as a government, these factors also come into play. Same factors, because at the end of the day, we want to be able to get value for money, and we need to be able to invest in health, which means that if we are going to spend 10 ringgit, how can we stretch this 10 ringgit? What kind of services or products can we get for this 10 ringgit, and can we get the best possible quality for the amount that we put in? This is not an easy conversation because there are a lot of issues at hand. And when you look at the price of drugs, for example, it's dependent upon whether the patents are still in effect, and sometimes the patents can last for 12 years or more. And this would mean that as a payer, as a country or government, or as somebody who is taking care of a healthcare system, you may have to pay more for a patented drug, which means that if you are only bound to this particular drug, you would end up having to pay a lot more than what you would pay for a generic. But the problem here is that not every innovative drug has a generic counterpart. There are a lot of pharmaceutical products out there, especially those that are involved in oncology, for rare diseases and so forth, for which there are no other pharmaceutical products or drugs that can be made available to be treated. So essentially, you are ending up having to pay a lot of money for one particular drug. So a conversation that very often happens in healthcare systems is that should I spend say 100,000 ringgit to provide for one patient this particular drug, when the same amount of money could be spent on 10 other patients who are having a different kind of disease. So there is very often this discussion about where should money be parked for which disease is much more important as compared to the number of patients and how much would it cost to care for them. One interesting finding from the recent WHO Ministry of Health non-communicable disease health economics study, they found that when they compared diabetes, cardiovascular disease, and cancer, they found that the disease that took up the most amount of money yearly was not CVD or cancer, which I would naturally think it would be the case. It was actually diabetes. And the reason for that is because the patient load, the disease burden, is a lot bigger for diabetes as compared to the other two diseases. So there's a lot of factors that come into play. And very often, the price of drugs, the disease burden, and most importantly, even the lifespan of the patients involved come into play when determining whether or not a payer wants to invest in providing care for that particular disease. So it's very complex, and sometimes it's life and death for many of these people whose lives are determined upon whether or not health systems feel that they are willing to invest in their care or not.
All right. Thank you very much, Mr. Azrul. Actually, there's I would like to actually explore more in regards to the question, where should the money be parked? But before we go into that, I think I'm going to go back to Prof. Dato and sort of ask a bit on the concept of health inclusivity. In terms of promoting health inclusivity through universal health coverage. So, Prof. Dato, in terms of universal health coverage, where would you say does Malaysia stand in regards to UHC? Would you characterize that in Malaysia, universal health coverage is something that has been applied fully, and if so, what has been the impact of universal health coverage on the Malaysian economy?
Yeah. If you look at the concept of universal health coverage, which was actually started back in 2007, so it's already about more than 16 years that this concept has been put forward by researchers, especially from UK. It is actually a follow-up of the concept of primary healthcare. In 1978, WHO launched a primary healthcare concept, with the idea of achieving what we call health for all goal by year 2000. In this concept, the important thing is that WHO try to gather support from all the countries in order to provide services to everybody in the world, every citizen in each country. But when we reach year 2000, there are still a lot of countries that are not able to do that. But one thing important about the primary healthcare concept is that in the definition of primary healthcare, they put in one important element, which is cost. If you look at the definition of primary health care, it's actually essential health services provided with to the population with a full participation at the cost that the community can afford. So the word cost, which actually reflect the resource use, has been there. In 2007, Professor Ann Mills from London School of Hygiene started this throwing this idea to encourage countries to relook at the concept of health for all. And universal health coverage was actually defined initially as an effort to ensure that everybody in the country will have access to good quality care. But this access to the services should not be determined by income, number one, their social status, and also should not be determined by their residency. But it should be linked to their preferences, which means that we give them choice to choose public or private facilities or wherever they want to go. So this is a very important concept, which is actually to me is a revisit of health for all by year 2000. But it is now linked to SDG goal. Under SDG goal number 3, universal health coverage has been put in as one of the key target. Has Malaysia achieved universal health coverage? This is very important concept, very important question. Many countries like to declare that they have achieved universal health coverage, but is that really happens or not? One thing we must remember, even if you achieve universal health coverage, you may not be able to sustain it in long term because you need a lot of things. You need resources, you need technology, we need political support in order to achieve that. If you talk about Malaysia, in terms of primary care services, where we have a good facilities for health centers and all that, maybe for the primary care services, we have achieved universal coverage, but not for the secondary and tertiary care, because access to secondary and tertiary care, major obstacle is still finance. And as today, we see that a lot of hospitals and secondary care were flooded with patients, and they cannot go to the private healthcare facilities to reduce this congestion because they don't have ways to actually finance them to provide to go and seek healthcare to these facilities. And last few years, there was a report on the achievement of universal health coverage. I think most countries, especially developing countries like Malaysia, the indicators that were used to assess the achievement of universal health coverage is between 60 to 70%. So which means that there are still a lot of work need to be done. And the important concept is that once, even if you achieve universal health coverage, you may not be able to sustain it without a strong mechanism. One important factor that actually fails many countries from achieving universal health coverage is lack of sustainable health financing. This is very important concept. And Malaysia, as Dr. Azrul has been mentioned, we have been talking about it for more than 30 years. Our neighbors have moved forward and they have instilled many packages to finance healthcare services. Good example is Indonesia, Thailand, and even Vietnam. In Indonesia, for example, 85% to 90% of the population will able to access public or private healthcare through a common health financing mechanism, which does not happen in Malaysia. So I think universal health coverage is a good concept, but we need a lot of effort in order to make sure that even if we achieve it at a certain level, we must actually have mechanism to sustain it in long term. And this is very important. You need a lot of resources in order to make sure that everybody will have access to good quality services.
Okay. All right. Thank you, Prof. Dato'. In regards to it being sustainable, I think that is one of the challenges in maintaining universal health coverage. So maybe, Prof. Dato', you can share with us in terms of sustainability. Are there any models of healthcare or health financing that has worked in other economics which are similar to Malaysia that can actually that we can actually consider adapting to our own country?
Yeah. Before I answer that question, I think let's look at the financing model that we have in our country and what are the trends. What we see in Malaysia at the moment, we are spending probably about 4.5% of our GDP totally for our healthcare. But within that 4.5%, there are big fragmentation. Nearly our population have to cough out their own pocket money, their own money from their own income, which is out of pocket expenditure, as high as 40% of the total expenditure, which is very high. If you compare to other countries, even our neighbor like Thailand, for example, they spend nearly about less than that, probably about 11 to 12% out of pocket expenditure. The rest are actually covered by a financing system that are organized by the government through the social health insurance program. So I think out-of-pocket expenditure is a major problem that actually remains as an obstacle for countries to achieve universal health coverage. When you say out-of-pocket expenditure, which means that people have to use their own service, their own income, and when they use their own income to purchase healthcare services, there are very little incentive and disincentive that the government can create to make sure that we have value for money. So if you pay out of pocket, and then the hospital might overcharge you, the clinics might overcharge you, and then there is no mechanism to ensure that the resources are efficient. WHO last few years has put a benchmark figure of not more than 20% of the total expenditure should be allowed for the out-of-pocket expenditure. So we are actually nearly double of that, which means that we have a huge obstacle in order to achieve universal health coverage or even to sustain it in long term. So if you look at many of the countries in the world, countries who have got a very strong health financing mechanism, especially through national health insurance, and my preference is a model of social health insurance, which have been implemented in countries like Vietnam, Thailand, our close neighbor, and also Indonesia for the past few years, and they have achieved tremendous development in terms of their health system, which Malaysia has still been lagging behind compared to these countries. I think one good thing about having a national health insurance or national health financing scheme is that we will be able to reduce the fragmentation of the resources that can be accumulated in one pool in order for us to actually introduce a mechanism, what we call strategic purchasing, where the purchase of the healthcare services is done by an entity created by the government, where we can build in incentive and disincentive in order for us to achieve what we call efficiency and quality of care. This is what we need to do. At the moment, we have our financing mechanism for 30 to 40% coming from out-of-pocket expenditure, and then we have EPF, we have SOCSO, which have their own health financing scheme, and we have MOH, which receive budget through our taxation. So all these are being fragmented. When it is fragmented, we will not be able to actually mobilize all the good mechanism in order to achieve efficiency and quality. So our buying power and also the value that we can create from the 4.5% of GDP that we have currently spent on healthcare is not there because it is fragmented, it is not organized. So we need to reorganize this. So even if we actually reorganize of what we already have now in one pool, we would be able to achieve higher value in terms of the way that we purchase healthcare services from both public and also private providers. One good thing is that health financing is a very important tool that can tie up both public and private sector in one mechanism of providing the services which can benefit the population.
Thank you, Prof. Dato. That was definitely an interesting insight in terms of financing models. Mr. Azrul, would you care to add on to the the issue at hand? Could you share with us your thoughts on any healthcare financing models that would benefit the country?
Thanks, Professor. It's a challenge for Malaysia because we very often forget that we have a two-tiered system, one that has the public sector and the private sector. And the private sector has been one that has been going on for decades now, which assumes in itself, arguably, a parallel set of services, one which is available for different group of people, and also is able to provide a certain and different type of care and services for those who are able to pay for it. And this is a little bit of a tricky situation because when you have two systems alongside each other, inevitably there will be conflict, there will be duplication, there will be a fair amount of competition as well, especially for resources. And we see this significantly impacting both, in fact. People feel that people who leave the public sector are going into the private sector. Therefore, you are basically depriving the public sector of nurses, doctors, even medical assistants and so forth. But when we look at it as a system, we find that there is a fair amount of disproportionate allocation of especially expertise. So you find that there are more specialists in the private sector than there are in the public sector. A lot of people who are working in public sector join the private sector for better opportunities, better pay, maybe research opportunities as well, and so forth. And so what very often happens is that people feel that the public sector is one which is providing inferior services and feel that they don't provide as good a service as in the private sector, because why would you leave a good system, right? But you find that essentially what then happens is that people depend, 70% of the population depend on the public health care system, and the other 30% on the private. But when you look at in terms of expertise, you find that a lot of them are in the private sector and not in the public sector. But the problem here is that we need to be able to look at which areas, like for example, infectious diseases. You don't find infectious disease expertise in the private sector because you can't make money out of ID. You want to be able to make money, you have to go for something that is much more acute, is able to be able to have patients who are able to be long-lived, because you want repeat business. So you find chronic diseases, some of them will be in areas for which the private sector emphasizes on. But things like TB, for example, you don't find in the private sector. That's all in public. So you find that there is allocation of resources problem, and some of that fragmentation that Prof. Said mentioned just now comes into play here. But there is also this mindset of paying for services and for medication and so forth. An analyst working in public health not too long ago asked the question, what's wrong with out-of-pocket payments being high? If people can afford to pay for better services in the private sector, then that is basically what we should be able to do, because insurance is also, private insurance that you take is also considered out-of-pocket payment. So the answer, the question that was asked by the analyst is that if people are willing to pay for better services in the private sector, then that is basically what we should be able to do. And that is basically what's happening. People feel that in the private sector, you can get better services, you can get faster, you don't have to wait for long queues, you don't have to wait for month-long appointments, you are paying for quality. So what is wrong with paying for that? That's all fine and good if you are catering to a certain class of patient. What about patients who have to pay out of pocket, which includes things like selling their house, mortgaging their house, selling their land, selling their motorcycles, and having to deplete their household savings in order to fund their healthcare. And that is, I think, one of the issues of concern that we have right now in a country like Malaysia, where very often you find that in the public sector, you cannot get a certain type of drug because it's too expensive for the government to pay for, but you can get it in the private sector. So you end up with patients who are depending on healthcare in the public sector, going to the private sector anyway to be able to access drugs which they cannot find because quota tak ada, they don't fall under the patient scheme, and therefore they have to pay out of pocket and pay maybe like 90,000, 100,000 ringgit per cycle in order to access the drugs that they need to be able to have a good quality of life or even to save their life. And so this is the problem we are seeing right now in Malaysia, where we have two systems which are existing parallel to each other, very often in competition with each other, and not necessarily providing the kind of sustainability or universality of the kind of healthcare that we expect. Right now, when we talk about universal healthcare, very often you look at the public sector. And that's what we talk about universal healthcare, because it's accessible to all. But we don't consider the private sector as being part of universal healthcare. Why is that? And the reason for that is really because the private sector is looked on as a service that only people who can afford it can access. So it's not part of our healthcare system when we're talking about universal healthcare, but it shouldn't. It should be part of it. We should be able to access services in the private sector in the same way that we access the public. And right now, we need a reform in the way we think about these systems, and how we pay for it. We should be able to have healthcare financing, which is able to access the private sector for whether it's fee for services or funding for a particular surgery that is not available in public, and you are paying or you're benefiting from the same pool of funds that you would expect from a healthcare financing system like a national health insurance. Right now, we don't have that. And so you're left to your own devices or having to pay with your own money to be able to have life-saving surgery in the private sector. And this is something that is very detrimental, because we are not solving problems. We are increasingly seeing a public sector that is seeing an explosion of NCDs because the population is increasingly unhealthy. And so you will never be able to catch up in terms of costs if we continue on with this tax revenue dependent funding system which we have today. We need to find new sources of funding, and we are not having that conversation because we feel that somehow the tax revenue that we have today is going to be enough to fund the entire healthcare system needs, which is growing by the year. And in fact, today, Prof. Sai, I don't know if you've seen an estimate of how much do we actually need to fund the public healthcare system. Because today, we see the annual budget increasing, but we don't know what the gap is between what we actually need versus what we are actually given. And that gap could be really big, because right now we have a funding for this year of 36 billion. What if the actual needs for the healthcare system is actually around 60 billion and the gap is 24 billion? So how is that gap being addressed? We haven't had that conversation, I think. And that's where innovative approaches to healthcare financing, which are sustainable, like national health insurance, need to be introduced. And unfortunately, this is it's great for Prof. Said and I to speak about this in this webinar, but actually it's also a political issue as well, because the public don't want to pay for their healthcare more than necessary, and this is something that we need to instill and have this conversation about investing in your own health. And we need to all pitch in, not some people, not just people who pay tax, but all of us. So how can we do that? And how to have that important conversation? I think it needs to be done there.
Thank you, Mr. Azrul. Actually, that begs a very important question, which I think it will be a bit cheeky for me to say this, but when you mentioned earlier about what the public is willing to pay, like for RM1 for registration and a checkup in a public facility, and if there's talk about increasing it and the whole population is going to be in an uproar, and then you'll have political issues coming up saying that the government is no longer supporting the rakyat and things like that. But realistically, I think what we're providing, the services we're providing for the cost that we're charging is alarmingly low. In terms of the cost that we are charging, as opposed to the value of the services that is being given. And when you talk about the two-tier system and having both a public and private healthcare in Malaysia, when we talk about health spending, it actually covers both, isn't it? That health spending includes public spending and also the private spending. So even though which always goes a bit unnoticed, that we talk about the public spending of healthcare, but in a two-tier system, and in Malaysia, we're divided into, I think we can say we're divided into two groups, where one group is dependent on the public healthcare and another group which are willing to spend on private. And the fact that the gap between the two tiers are so wide, and where private spending is also escalating, I think that will have an impact on the Malaysian economy also, isn't it? That health spending actually increase is at a rate which is very high and can also be an economic burden to the country, isn't it? But I guess the question that is being asked in terms of finding new resources to fund the system, is that more a political issue, or is that an economy issue for our country? Maybe Mr. Azrul or even Prof Said would like to answer that. What's stopping?
I just want to follow up on the question raised by Dr. Azrul regarding how much do we need for our healthcare services in Malaysia. I think over the years I've been talking about this. We don't have a very good figure to actually look at and to forecast, but we look at the pattern from other countries. So if you look at the OECD countries, they spend on average about 10% of their GDP. And Malaysia are spending about 4.5% of our GDP. Are we able to achieve about 10% of our GDP? That's a big question whether we can afford it. If you look at the overall average for the whole 195 countries in the world, the average is around about 9% of the GDP. And among the developing countries itself is about 7 to 8% of the GDP. So my proposal earlier on, when we were doing a mega science project a few years back, we proposed that Malaysia should actually target for at least 6 to 7% of our GDP. And if you look at the conversation from the health white paper, and the Minister of Health at that time, KJ Khairi Jamaluddin, has mentioned that they want to increase the public budget in the public sector itself to 5%. Currently, it's about 2.5%. If you break up public and private sector, 2.5%. That means that you need to double what the MOH is getting now. The MOH is getting what 35 billion per year. So that will actually needs to at least 70 billion per year. If we do that, we don't touch the private sector. That means we will reach probably about 6% of our GDP. To me, this is a very good figure if we can actually manage this. Currently, the issue of having a pool resources is very important because it gives a lot of chances for us to actually put in the ideas of efficiency and also the and effectiveness in the concept of managing pool resources. At the moment, we have EPF. They have a special account for healthcare, which is not probably being managed properly. We have SOCSO, which actually very rich with a lot of resources. They manage their own resources as well on healthcare, which actually to a certain extent is not being pulled together. So even if we have, we go to 6 to 7% of the total GDP of GDP for our healthcare, that will give a lot of weightage for our health system to be moved forward in a more inclusive and also more effective manner to manage the resources. So then we can include in a lot of tools in order for us to increase the value of the money. For example, I'm very supportive of the concept of strategic purchasing, where the purchase of the healthcare services in the public as well as private sector is done through a tool that can help to achieve the level of equity as well as level of efficiency. We cannot do that at the moment because the system is so fragmented, and this is where the strength of having the health financing. Of course, we need a lot of political support, and I think I also like to respond to Dr. Azrul's raised the issue of people asking why is it we have a high, is it a problem if we have a high out-of-pocket expenditure? This is something that why is it WHO reduce the level of out-of-pocket expenditure from 30% to 20%? Because of various reasons. One of the reasons we know that the higher the out-of-pocket expenditure, that means that more likely that people will go into what we call catastrophic expenditure. These are people who are actually not poor, but they become poor because of their sickness. This is the major problem. And secondly, if we have high out-of-pocket expenditure, we will not be able to purchase the services on behalf of the population and initiate the idea of strategic purchasing. So all these are actually the elements of having high out-of-pocket expenditure, which WHO is very concerned about. And one of the major obstacles of achieving universal health coverage is actually high out-of-pocket expenditure. So that's why we have to actually fight against this. And we know that, for example, if people purchase insurance, that is also an example of out-of-pocket expenditure. But when you purchase insurance, your money is not being managed by yourself alone, and you stretch the value of money because we put in all other things that the pool resources can be used in more effective manner. So I think that is the important aspect that we have to remember, and we have to keep on this discussion so that we will have a stronger political will to move forward. Right now, with the health white paper, we can see there is some movement, but to me, this is just not enough yet. We need to see things are being put forward, and we need to actually walk the talk.
Actually, if I may respond also to some of the points mentioned just now, Prof.
Yeah.
You know, Malaysia sometimes does things in a very expensive manner, which is sometimes very odd for a country that sometimes claims to be a developing country. You know, when you look at pool procurement, for example, we don't do pool procurement. We didn't do it until recently. You know, like purchasing of drugs, there are three purchases: the Ministry of Health, the Ministry of Higher Education, and the Ministry of Defense. Each of them purchase their drugs separately, and what is usually the approach in many other countries is for there to be one purchaser, but it benefits three. And in Malaysia, we have each of the three having their own negotiation, having their own arrangement, and of course, it costs more. So we've only just recently introduced the pool procurement approach, where there is only one purchaser. So you can find, funny enough, you know, if you take paracetamol, you can actually have three different prices for that paracetamol because of the different volume and the negotiations that they've had with the supplier. So right now, even like that, which is very simple, we should be able to do better and to streamline rather than have this fragmented approach to something as straightforward as procurement. So there's a lot that we can already benefit. You know, there's a discussion right now at the international level where perhaps we can even do pool procurement amongst countries, not just within a country, but, you know, like Malaysia, Indonesia, Thailand can purchase their drugs together as a block and benefit from a higher volume and a much more lower cost price. So there's a lot of discussions there that could actually benefit the country as a whole. You know, I also wanted to just mention that, you know, like this 1 ringgit 5 5 ringgit thing, if you look at the breakdown, because somebody was asking online not too long ago, how much money does it actually bring in? You find that the breakdown is providing user fees at around 400 million. 400 million is how much that people who are having to pay into the public sector is contributing to the overall cost recovery. 400 million. But actually, 400 million, out of that 400 million, 60% is paid by foreigners. So only 40% is from locals. So if you can imagine how much this 1 ringgit, 5 ringgit collection contributes back into cost recovery, it's actually a very, very small number. So our position at the Galen Centre is to get rid of this 1 ringgit, 5 ringgit collection at the point of care altogether, because there's no point in trying to do this collection, which is burdening the nurses at the front desk, but also distracting from healthcare reforms. I mean, today there's a fight going on online in terms of increasing 1 ringgit to 10 ringgit. But even an increase of 1 ringgit to that initial amount is 100% increase. If you increase from 1 ringgit to 2 ringgit, that's 100%. So nobody wants to see 100% increase in how much they pay at the front of the desk, right? It's not political. It's not going to be acceptable. The public also won't understand. So for me, just get rid of it. We don't need this 1 ringgit, 5 ringgit collection. And let's have proper healthcare financing discussions, you know, and this is what's happening right now, because today, if we are going to continue on with the current financing system that we have today, we will forever be chasing the tail of the tiger that is in front of us. And unfortunately, the tiger is going to be faster than us, and we're just going to be forced to just look at that tail. And the tail, this tiger that I'm talking about is really the tiger of non-communicable diseases, which is inflicting at least 70% of the population. You know, and when you think about, in terms of, again, using diabetes example, the fact that in this country, 4 million people are living, and some of them are undiagnosed with diabetes, means that this is 4 million people that we're going to have to care for, and that we're going to have to figure out how to pay for that care, and that's lifelong. And that bill is increasing because the number of people who are living with diabetes is increasing. So, and that's just using diabetes as an example. So today, we really need to have some of these difficult conversations. But I think going back to the topic of this webinar, which is very important, which is inclusivity, we have to make sure that people are not left behind. And this means that we need to ensure that we are able to provide the best possible coverage with the best possible care, which means we need more money. And as mentioned just now by Prof. Syed, this 5% that the previous health minister was arguing for with the previous government actually represents 100% increase in the allocation that we have today, from 36 billion to 72 billion. So where are we going to get this 36 billion? You know, GST itself collected, I think, around 16 billion in terms of collection. So how are we going to collect? How are we going to find this new money? And that's going to be the question that needs to be answered, because we are not able to provide this 5% today. It's wishful thinking to think that we're able to use the existing tax revenue to provide for this 5%.
Yeah, I would like to support the ideas that you throw regarding the use of the user fees, the 1 ringgit to 5 ringgit. Actually, this is not something new. In the early 80s and also late 70s, user fees was actually proposed by World Bank as one of the mechanism to raise fund. But it fails miserably. There were a lot of studies which shows that when we introduce user fees, there are a lot of side effects in terms of the people going below the poverty line. And more importantly is that if now we were increased to actually from 1 ringgit to 5 ringgit and also to 10 ringgit, there are other things that can happen. Number one, in terms of the collective collection mechanism, MOH will not have all the capacity to actually do that. You get RM1, but then from the people, but then you want to chase those who actually do not want to pay, or they go into the hospital and then they discharge themselves out, they refuse to pay. To chase them out for non-payers, you spend a lot more than that. So even if you accumulate 400 million per year, you spend much more to actually manage the system. So it actually creates a lot of problem. And then again, if we use user fees itself, I think the conversation of moving from RM1 to RM5 or to RM10, it actually at the moment is really absolute kind of thing that we should be discussing. Whereas if you use that money to purchase social health insurance program, you will have a lot more values in that, because it will be a pooling of resources and a lot more things can be done. Indonesia, for example, they have a population of 278 million. Their social health insurance cost them only about 20,000 rupees per person, which is about RM8 per month. So in 1 year, about RM100 that they spend in Indonesia, they will be able to access all these kind of services. Even they are allowed, they can go to even to the private hospital to get their healthcare services without paying any additional costs. So this is the power of having a social health insurance program, which I think our country should look seriously into this, and stop talking about raising the fund or raising the user fees from $1 to RM5 and all that. We are not in the era of the African countries in the 70s or the 80s. I think those people who are thinking in that line, I think they do not know what is the idea of having a good pool resources which you can actually mobilize our health system properly. That's my view on that. I think it's a good idea if Dr. Azrul can communicate to them that this is not the way forward. Actually, we should not be deliberating on this issue, but actually try to focus on how we can get pool resources.
All right. Thank you, Prof. Said and Mr. Azrul. Just now it was interesting that Prof. Said mentioned that we have the white paper, health white paper in the pipeline now that is supposed to sort of look into a health reform. But and I would agree with the suggestion for pooled resources as a new source of funding. But I'm not sure who would I like to throw this question to. But in terms of the white paper, how do I say, how supportive of the reform is the white paper? Does it indicate in the white paper that is the hala tuju, or the pathway that Malaysia is going for a health reform towards moving away from government taxation as a source of funding and more towards national insurance or a pooled resource? Would Mr. Azrul like to comment on that, or maybe both? I can get both of you to comment on that.
Prof. Said first, lah.
Okay. So I might have some conflict of interest here because I'm in the committee for the health white paper. I think to answer your question whether we need the reform, I think that's an absolute yes. We need the reform because we cannot do piecemeal kind of changes. We need to have a big bang kind of change. And you look at the health sector reform that are being, or the health white paper, the reform consists of 4 different pillars. It talks about how they want to reorganize the delivery of the healthcare services. Maybe this one is actually in response to the congestion of the public facilities by people. Number 2 is actually to focus more on health promotion. That's very important concept. And then the third pillar is actually the ensuring sustainability and equitable health financing. And this comes under the third pillar. And the fourth pillar is strengthening health system foundation and governance. If you look at all these four pillars, the other 3 pillars will not work if you don't have the third pillar, which is the health financing. Because the easiest way to actually introduce or to reorganize the health system and also to increase the networking between the public and private sector is to have a common health financing system. So all these 4 pillars, I think, is very important. And we heard that this month, MOH will actually present this health white paper to the Parliament for the approval. And after this approval from the Parliament, then there will be a lot of work need to be done in order to actually move this reform in a strategic manner. And of course, the reform will take between 15 to 20 years to actually implement this. And one of the important aspects is actually on financing, which we cannot actually sort of we cannot actually leave this alone. It has to be done concurrently with the other three pillars. Yeah.
Okay. Thank you, Prof. Mr. Azrul, would you like to comment on that?
Well, the final version of the white paper we'll know in the next couple of days. Hopefully, it will be tabled in Parliament. We still don't have word yet as to when this is going to happen, but also that the final version of this document is also one that has been worked on a few times now, and we basically need to manage our expectations concerning what is in this document. Having said that, though, what we really need to do is to really figure out a way forward that involves putting together a realistic, ambitious, bold, and transformative blueprint for health in general for the way forward. I don't feel that the health white paper is necessarily it. I do hear a lot of people talking about it like as if it was the holy grail. Now, I wish that was so, but it takes a lot of political will to put together the necessary reforms. And the white paper could be one document, but the reforms behind it could be like maybe 20, 25, even 30 reforms that are needed in order to realize the vision that's in the white paper. And that's very important to emphasize, because the white paper is not an end onto itself. It's the beginning of a very long marathon, and it's something that we need to be able to ensure that there is support behind it for all the necessary things that need to be done. The reason why it's being tabled in Parliament is to sort of illustrate that support. That the people's representatives in Parliament are supporting the health white paper. So that's supposed to be the representation there. But again, the white paper itself will not have spelt out the specific changes that need to be done, what needs to be done necessarily, and that's where the work actually is quite unfinished today. A lot of people are already working on it, like Prof. Said has been working on it for years in terms of trying to put together recommendation of healthcare financing, and we can see where that's gone. We're still using a system that dates back to the 80s. A lot of people don't realize that this system that we depend on is really not fit for purpose anymore. And the question that we all have to bear in mind here is that through a lot of luck, but most importantly, the sacrifice and the investments that were made into our healthcare system over decades enabled for us to come out from the COVID crisis better than a lot of other countries. But the problem right now is, and it is on the minds of almost everybody who works in public health and infectious diseases specifically, is what happens if another pandemic were to come. And Malaysia today is in a much more vulnerable state than it was in 2019. This is the reality that we have to face. We have fewer doctors, we have fewer specialists. If you look at the number of people who have left the public health service, it's shocking. If you find the data, you compare from 5 years ago to 2022, the number of doctors who have left the service have increased by 1,000%. So we are today a lot more vulnerable than we were in 2019. So how do we go about building back the healthcare system to where it was, but also how do we invest in the future? So that's two separate conversations. And unfortunately, we're still not where we should be in terms of that 2019 yardstick. You know, there's fatigue, there's burnout, there's PTSD, and of course, there is the underinvestment in that continues to be a bane in our in the way we approach health, and we still don't have solutions that are acceptable to the public and the political side of things. And unfortunately, and this is where myself and Prof. Said are probably why we are not politicians, we're not running for office, is that we're promoting possible solutions that are not popular. You know, involves a national health insurance, asking people to contribute part of their paycheck into a pooled resource, basically asking for people to pay more, co-payment. I don't know if Prof. Said agrees with that, but I put forward a co-payment proposal for diabetes, for example. You know, so all of this is about growing the money that we have today. It's not about tapping on a depleting resource. We're growing new resources of funding that we need to be able to invest into the healthcare system back to recover from COVID-19 and for the future. So, you know, it's something that unfortunately the white paper will not be the solution in itself. We need to look at that document and see what are the difficult changes that need to be made and to actually make those changes.
All right. Thank you, Mr. Azrul, and also Prof. Said. I think that was a very good comment on the the way forward and where we stand at the moment in regards of the health white paper. Of course, I think all of us are waiting to see the white paper tabled soon. Um, and actually, we already have quite a number of questions from the audience. But before I open the floor for the Q&A, actually, there is a topic which I personally would like to ask Prof. Said in regards to health economics and financing. I understand that you have conducted a lot of research in regards to health economics and financing, but in terms of Malaysia as a country, where do we stand in terms of economic evaluations of our healthcare interventions? Are the decisions that are being made in our country mainly based on economics, or is it based on humanitarian policies, or is it due to or owed to political will? How
Yeah.
do we decide on the way our healthcare is run? Prof. Said, if you could elaborate on that.
I think over the years, I think since I came back with the idea of trying to propagate the use of economic as one of the tools for us to manage health system, I think we have been doing a lot of research, as you have mentioned, and we also have done a lot of training for people in MOH and also other decision makers to understand how we can use economic information for us to make decision. I think over the years, Ministry of Health has taken up this idea. They has established one of the important unit, which is not even it is not ideal, but it is a good start. They have the HTA Health Technology Assessment, and over the years, we have been working with them. Our association, Malaysian Health Economic Association, ISPOR, which is International Society for Pharmacoeconomic and Outcome Research, the Malaysian chapter. We try to work with them and then create this initiative so that whenever there's a new drugs that need to be implemented, they have to be subjected to the economic evaluation. And we have at least 3 different type of study that the anybody who want to submit new drug that they must submit, apart from the safety profile and all that, they need to do the economic burden study to make sure that the disease or the condition that are going to be managed by this new drug, this new technology is huge enough for us to actually concern with, and also how much is the resources that is required. Number two, they have to come up with the cost effectiveness analysis to show that this intervention is much more superior compared to existing technology, or maybe a comparative drugs, for example. And the third thing is that they must also come up with the budget impact analysis. So these three tools were increasingly being used as a mechanism to actually assess new technology that come into the industry, which are going to be funded by taxpayers. So far, they are doing quite well. Of course, they are overwhelmed with so many requests, but I think we are moving towards more decision which is made on economic evaluation, economic data that we need. But of course, it is poses a lot of challenges. There might be still some drug or intervention which actually gone through these processes not being vetted properly. But this is some of the weaknesses that we are facing, but it's very minor. At least we have this HTA. The ideal HTA is, of course, health technology assessment is in UK, where they have an independent institute, which is outside Ministry of Health, so that there will be no conflict of interest in order for them to provide a good advice to the government to fund or not to fund certain services. Our HTA is within Ministry of Health, but there is a suggestion that it should be an independent body, so that we can use this as an agency that assess all the new technologies. It's very important because all the technologies are very expensive now, and we want to make sure that if there is a new technology that being put forward, we must make sure that this is much superior than what we have, and it actually proved to be value for money. So in that way, I think we have tried to contribute quite a lot, but of course, we do a lot of trainings at the moment to keep on moving into a proper direction and encourage policymakers to start using data that are being analyzed to make decision, and not just based on their own gut feeling or their own personal observation, which is not valid to a certain extent. So I think that's what we are doing at the moment.
Okay, thank you, Prof. Yeah, I think thank you for the very informative comment. Yes, Mr. Azrul.
Yeah, can I just one thing to add on to Prof. Said's emphasis on getting the evidence, making use of real world data, for example, and to be guided by that. Because very often, and this is something that we find, it's not unique to Malaysia. Many other countries also have this problem, which is that despite the studies, despite the data, despite the evidence showing that it is cost effective to make a decision that is based on things like an HTA, very often governments don't follow the evidence, and they don't really make the policy based on the data that is provided, meaning basically going against the recommendation or just ignoring it altogether, and this is something that is very problematic, because you are arguing for value for money, and the evidence is showing for value for money, but it involves an earlier investment to be made. So very often the discussion becomes, how much is that ventilator, how much is that equipment going to cost, how much is that drug going to cost, rather than is it, does it make sense to invest in that particular drug in order to improve upon the qualities or dailies later on, or increasing the quality of life, or avoiding premature death, or even going on to insulin and so forth. So it's very important for decisions to be guided by evidence and data. And it's no point if people like Prof. Said does the training, builds up the capacity of the ability for them to be able to understand and to generate the kind of data necessary to guide decision making, and then it's ignored altogether. So this needs to be emphasized, that we need to get used to doing this, which is, even though it may feel like it's expensive at the very beginning, it's actually the decision making must be based on what we understand of investment in how we approach healthcare.
Thank you, Mr. Azrul. I totally agree. It's good to know that we have a system in place that actually, objectively identifies the solutions or evaluates, but I definitely agree with you that that system would be useless if it's not being heeded to. I mean, we have the answers, we have the recommendations, but if the decisions ultimately are not being done according to, you know, the results of the evaluation, then it would be a total waste of time and energy also.
Dr. Budi, can I just comment on this, just to follow up on what Dr. Asros mentioned
Oh, definitely.
regarding failure of the government to follow the recommendation that we did. You know, a politician being a politician, they always take advantage of the situation. Even today, if you look at the current debate on the discussion that was put forward in Parliament to discuss the audit report on certain things, you know, when it comes to COVID-19 pandemic, there are a lot of abuses of power being seen and being reported because suddenly the decision was not transparent. People use the emergency clause to actually make decisions, and then there were a lot of direct negotiation which was given to certain companies which have linked to the politician. I think things are coming out now, and drugs were actually being purchased. Vaccine were being purchased much higher than the actual price. There was a report in African country that the vaccines was actually bought by Ministry of Health at 4 or 5 times the market price for various reasons, you know. And in Malaysia, we do not know so much about this, but I think things are coming out slowly. Currently in the parliament, people are talking about the purchase of ventilators which were not delivered and all that, you know. So abuse of power and advantage taken by the politicians to actually circumvent all these things that we try to put in professionally is always there, and we have to be very vigilant about this. Yeah.
I totally agree, Prof. Thank you very much for the very informative comments and answers. Okay, as much as I would like to, I have other questions I myself would like to pose to both the panels. I think it's only fair that I open the floor to some questions from the audience. We have collected quite a selection, and we will try to address as many as we can as the time allows. The first question is from I think Dr. Wirdati Radzi. The question is, health has a price and can be financially defined, but what kind of definitions are we attaching to our health in Malaysia? I think for this question, maybe I give it to Mr. Azrul to answer.
Well, it's a really good question, and this is where the valuation of health differs from one country to the next. A lot of countries now look towards investing in preventative health, meaning what you want to be able to do is have a system that is able to encourage you to avoid getting disease or falling sick, and incentivizes you, provides the kind of tools for you to stay healthy. And when you are sick, it's there for you to be able to be cared for, to get the best possible treatment. And basically, your emphasis in that situation is really about getting well. But there are other systems, other countries, other jurisdictions where the health system is something that you totally divorce from your mind. It has no relevance to you until you fall sick, you have a catastrophic injury, or you grievous injury, or you are suffering from chronic disease, and then suddenly the health system comes into your consciousness, and it is something there that you then take advantage of. And this is something that is very much prevalent in many countries, and in fact, most of in our lives, there is no reason for us to visit a clinic or doctor or a hospital for that matter, and so health system doesn't really feature much. But we've learned in many other countries where their populations are healthier, that there are fewer people who are visiting the hospital, or filling in emergency departments, filling up hospital beds and so forth, that it's much more cost effective to be able to invest in preventative health, because when you do fall sick, it's very likely to have a heavy price. And the average household cannot assume the burden of a catastrophic payment at one go, unless you have a lot of reserves, a lot of savings. And at the end of the day, individuals, households should never be expected to take on that kind of burden. But we find that in a country like Malaysia, more and more households are burdened with catastrophic expenditure, which is basically defined as 30% of household income. So we seem to think that this is something to be expected. But should health be described in terms of monetary terms? And this is where we ourselves as a people, as a society, needs to be able to figure that out. Because I like to think that health is really about what kind of life can you have where you are able to do the things that you want to be able to do the kind of jobs that you want, to be able to have a fulfilling life, to be able to have a family, have kids, to grow old and not fall sick. I mean, that would be my way of defining health. But for a lot of people, health is really only important when they fall sick. And that's when, if you're trying to invest in healthcare, if you're only doing it then, it's already too late. And for a lot of people, that seems to be the case. That's why we describe health in Malaysia very often in monetary terms, which is a pity, because if we're doing that, we have to invest. And that's why insurance, for example, penetration in this country is very low, because people don't see the point of contributing each month into something that they can't get any result out from. Only 30% of the population have some kind of insurance, and very often it's the wrong type of insurance. They have life insurance instead of health insurance. So they go to a hospital thinking, oh, I've got it covered. I'm going to be able to pay for my healthcare, only to find out, oh, I'm sorry, you have life insurance. It's not health insurance, so you're still going to have to pay for your care anyway. So this is where I think we ourselves have to determine what is health, because right now the discussion online is healthcare 1 ringgit or 5 ringgit? Is this the value of doctors' services? Should it continue to be? Should it be 10 ringgit? Should it be 50 ringgit, and so forth? So I think it's an ongoing conversation there. But I think each of us have to decide what is health and how much do we attach value to it and invest. I think we have to take responsibility for our own healthcare as well right now. There's too much of expecting the government to care for us when we're ill without we ourselves putting any investment in our healthcare.
Right. Thank you, Mr. Azrul. I guess investing in health, the concept is akin to delayed gratification. Well, not so much gratification, but we have to invest now in order not to suffer later, and that's true for preventive measures too. And I think it's a mindset that needs to be changed within our population so that they will be more on board with the concept of investing in insurance and investing in something that they can't see the need for it possibly at this point of time, but it's for the future. Okay, the next question, we have another question also from Dr. Wirdati Radzi. This question, maybe I'll get Prof. Said to address. Will healthcare ultimately be discriminatory to the public based on the economic ability of the people?
Okay. Very important question for us to think about. there is at least four different objective of health system. Number one, we are talking about quality, efficiency, and then we are talking about the ability for us to provide the services to the poor, which is equity. The third objective is very important, which is equity. Equity is a sense that when it is defined, it reflects the fairness of the system in order to provide healthcare services based on people needs, not their ability to pay. This is the concept that are being adopted by World Health Organization and many countries. As much as we want to achieve quality of services, we want to achieve efficiency, but we must not forget the issue of equity. Equity, which a concept which actually protects people who are not able to pay, but they are able to access healthcare services through the system. That's why when we design any healthcare financing system, we must have this clause in order for us to provide healthcare services to everybody. That's why we need to, in social health insurance, we pool the resources together. The poor and the rich are in the same pool, and they get the same services according. The only differentiate the level of services is their healthcare needs, but not their ability to pay. In health economics, we have to we normally emphasize on the differentiation, which is between willingness to pay and ability to pay. Some people are willing to pay, but they're just not able to pay. Whereas ability to pay is what we are concerned with. People who do not have enough income, for example, they will not be able to access. So if we don't take care of this, we will fail in this. So if we have a system that discriminate this in any way, that means we fail on the third objective of the healthcare system, which is equity. And this need to be avoided. We know very well that people who are in this category, we don't manage them. It's not only socially wrong, but it is also put the whole population in the risk. Because we know that in healthcare there is something what we call externalities. The poor, if they suffer from infectious disease, they are not the only one who will suffer, but it will also affect the whole population. So concept of externalities is very important in healthcare. It's different from other commodity. Healthcare is actually very unique in that sense. So if you don't protect the poor, who may not have the ability to pay, then it will affect the whole population. The disease will spread to other people. That's why we must actually emphasize a lot on equity. The concept of social health insurance, the concept of uh, universal coverage through health financing is actually to make sure that the access to healthcare services is not actually linked to their ability to pay. That's very important. That's why you must have a strong health financing system. The universal health coverage concept itself will solve or try to solve the issue of equity. And one of the important aspects of the universal health coverage is to protect the poor. So this must always be a very important aspect. I think today our government is focusing on Malaysia Madani. I think this is the way forward. We are moving to this direction, and we hope that we will be able to protect the poor. It is a responsibility for everybody in the system to actually protect the poor, protect those who are unable to pay, so that we will not have a discriminatory kind of health system.
Okay, thank you, Prof. Um, the next question that we have, I would like to give it to Mr. Azrul. It's from Dr. Zarif Zabari. The question is it possible to start seeing our healthcare services as a business model rather than just services? Take a look at Tabung Haji Amara. They provide services but also run it like a business.
Well, arguably, you could say that we've always looked at it as a form of business. It's just not the money-making kind, or we're losing money in terms of this business. So, and the benefit really is really seen in untangible outputs, or basically, if a patient walks out of the hospital cured and treated of their ailments, what is the valuation there? I mean, what is the value of that service? You know, we haven't really done that well enough. But that's where very often you hear this phrase being talked about how we should transform our healthcare system from sick care to one that is of wellness, well-being, and so forth. So we need to put that in terms of dollars and cents, I think, and that's important for us to look at, because I can tell you that there is benefit to looking at it from a business perspective. In fact, to some extent, when you talk about health economics, I feel that is a very important way to look at the world based on realistic concepts, determinants. I think we mentioned just now commercial determinants, which ultimately affect whether or not we're able to deliver the kind of treatment and care for the population. So it is important for us to have a realistic outlook on how we look at healthcare. But at the same time, this is where, when you look at the costs concerning the private sector, and this is very important to appreciate, is that you go to the private sector and you look at the bill that comes out after you've been discharged from hospital, and you go, oh my God, I have to pay 9,000 ringgit, and then you compare it against a bill that comes out from the public sector, and the amount is 300 ringgit. The question that would be asked is, which one reflects the actual cost of healthcare? Now, I would argue that actually the private sector bill, minus its profits, would actually be more closer to the actual cost of healthcare for both the public and private sector. But because subsidization of healthcare is so high in Malaysia for the public sector, which is around 98%, we are lulled into thinking that public sector services are cheap or free. In fact, I noticed in your introductory video just now for Smile, I think, talking about free services for, I think, dental services. I think that needs to be corrected. We shouldn't be describing it as free. We should be talking about it as at no cost to patients, or subsidized by the government, or paid for by taxpayers' money and so forth. The term free really shouldn't be used to describe these services, because I can show you that Tamu Haji and Mara and all those others, EPF including, they don't look at things as free, and they need to see return on investment and value for money. And I think for our healthcare system, to some extent, we need to have a better look at what we understand by value. Value should not be the cheapest medical device or cheapest drug that's available by the provider, but more the point is the value should be what is the health outcome that we can get from investing in a particular drug or medical device and so forth. What does it do for patients? Does it mean that I won't see that patient again in a hospital after just 1 week and so forth? So those are the kind of descriptors that we need to look at, health outcomes, which are described in terms of a business model. I think that's doable.
Okay, thank you, Ms. Azra. I'm going to have to move on if we want to, take as many questions as we can. So the next question is from Dr. Muhammad Faiz bin Muhammad Hanim. It is quite interesting on the idea of introducing social health insurance. However, is it a way forward for our health financing solely without any top-up from the tax revenue financing? So for this question, can I have Prof. Said to address it?
Yeah. Thanks, Mr. Muhammad Faiz, for this important question. When we talk about social health insurance, we always emphasize that this is not the social health insurance. The source of funding can come from the various sources. One of it is actually tax-based, because if you look at the social health insurance program in other countries, the poor are always being covered by the tax-based system. The government contributes a lot from the tax-based system. For example, in Indonesia, 80 million people are in the level of below the poverty level. They don't have to purchase any health insurance. The premium are paid by the government through the taxation. So the tax is always an important source of funding, maybe as high as 20 to 30% of the resources that are being received by Ministry of Health now will be in that particular in that system to cover not only the poor but also to cover other services which may not be feasible to be funded by social health insurance. For example, a lot of preventive services, a lot of things that are being done in order to create value for health promotion. All these have to be paid through the taxation. So tax revenue is one of the source of funding, apart from premium paid by people, and also from other contribution from the workers through the SOCSO and also EPF contribution. No social health insurance in the world survive only on the premium that they are going to be charged. Only private insurance depend on premium most of the time. The private insurance normally depend on premium, and also they depends on the cut that they make when they negotiate with the with the providers. So I think we always emphasize this idea, and I think they will come out in more detail when the team form a committee to actually design social insurance for Malaysia in the near future after the health white paper is approved by the government. That's what being stated by the minister before.
Okay, thank you. Thank you, Prof. Syed. Okay, the next question is from Dr. Zarif Zabari. The question is, we talk about high care services to all citizens or inclusivity, but with the progressive brain drain phenomena or emigration, how bad is the economic impact and what should we do to lessen the consequences? Okay, Mr. Azrul, would you like to address this?
Thanks, Prof. This is an important question concerning the brain drain, and it's important for us to take a realistic view of the issue. And I feel that sometimes the politics and also our own misplaced nationalism sometimes comes into play with regards to the issue of addressing the hemorrhage of talent that's coming out from our healthcare sector. Now, when we talk about this drain, it's one thing for our doctors, nurses, specialists, and so forth, our healthcare workers to move from one side of the table to the other side of the table, from public sector to private sector. But what is worse is if they leave the country altogether, or they leave the field, they leave medicine. And we have had more and more of the latter in the past couple of years because of the trauma and burnout caused by COVID-19, and something that we still haven't been able to describe properly. But we also have more people leaving the country for other countries like the UK, to Japan, to Australia, to New Zealand, and these countries, and Singapore, and these countries are offering more and more incentives, higher salaries, and we are unable to compete. So the fact of the matter is that we are losing our best and brightest, and it's taking us even harder, longer, and more expensive for us to be able to replace them. So the fact is that this is happening in the country. What we seem to not be able to accept and fully understand is that we are not able to replace these people with the new class of medical students, nurses, and so forth in a manner in which it is directly proportionate to expertise, to experience, to skills, and so forth. So what we need to consider very seriously is to liberalize our approach to human resource. We need to start looking at what other countries have considered, are depending on, which is to open up the healthcare sector to foreign workers, to foreign doctors, nurses, to be able to staff our healthcare facilities to provide the services that we need. You know, a lot of people don't know this, but the private sector today is actually experiencing a massive shortage of nurses to such an extent that they are having to force the closure of their wards because under the law, they need a certain number of nurses in order to staff uh, one ward. So they don't have enough to do that. It's so bad that even with the salaries and wages that they're paying, they're having to close wards. The public sector, on the other hand, doesn't seem to experience this because it doesn't really conform to the same regulatory requirements as it imposes on the private sector. So you can have, as many patients, as many wards open, and wards don't necessarily close with the number of nurses that they have. But guess what? It's gotten so bad that I think Hospital Sultan Ismail in Johor has even had to close their wards because they don't have enough staff. So we are experiencing a massive, it's not progressive, it's actually a drastic brain drain. We are at the point where we are having to close hospitals, wards and hospitals and clinics because we don't have enough staff. And we need to address the problem. And we might need to bring in people from outside the country in order to alleviate that. Because we have to focus, we need to deliver services. We need to provide care, treatment. How do we go about this? We need manpower. Where are we going to get the manpower? We can no longer depend on the domestic supply, which means we have to consider bringing in nurses from other countries to work in our country. And that is a very tough decision to make, but it's going to be something that we consider.
Okay. Thank you, Mr. Azrul. There is one last question. It is quite related to what we are currently discussing. This question is from Dr. Munira. Are the incentives given by the government to specialists and health staff sufficient to cause them to stay working with the government? And are the incentives given fair to rakyat who are still unable to get the services they deserve? Since this is the last question, I'm just going to throw it out there. If it can be answered by either Prof. Said or Mr. Azrul. Any takers?
Yeah, maybe I'll start first based on some of the observation have been going on within the health system of Malaysia. Actually, whatever incentive that you created within the government sector, it will not be enough. It will not be able to match what they can earn in the private sector. In fact, we have to actually be more realistic in trying to address this issue. If you look at the government specialists and also staff in the health sector, even if the salary is probably much more lower than what they can get but they have other fringe benefit. For example, they will have a pension scheme which they can enjoy after they have retired, and at the same time, there's other fringe benefit which is not so bad compared to if they work totally in the private sector. But over the years, government has created some mechanism in order to try to actually attract them and also to retain them in the private sector, which to a certain extent, I have a lot of reservation on that. Government introduced what we call the full paying wards, which is basically a situation where people can actually opt to pay for their services, but then they will get a faster treatment if they were to pay a certain fees to the wards, to the government hospital. This is very controversial issues, and I have a lot of reservation on this because what happens if you create this, you are basically privatizing the healthcare services, and the worst case scenario is that when patients say that okay, I'll pay and I'll go for full paying ward, they can cut queues, they can get the operation done faster and all that. But what will happen to those who are actually in the system where they have to wait longer? So this is very unethical kind of a thing which has happened. So if you say you go to see a public sector doctor, you need an operation for slip disc, for example, and they say that Makcik, you have to wait for 6 months if you want to go into the normal system. But if you pay through the full paying ward, I can do it within the next 2-3 weeks. So they use the same facilities in the operation theater.
Same
but
people.
why suddenly they are allowed to cut queues? This will make things worse. So even for, if it is this mechanism to create incentive for doctors, but this is very unethical. I think the current government should review this. At the end of the day, will this system be able to reduce the outflow of doctors into the private sector? I think there's no evidence to show that it will help to reduce the. In fact, more of them might go out because they use this mechanism to try their private market, before they go out. So this system is very unethical, and I think we have to think outside the box, not to implement this such very inequitable and unethical system that is going on in the system at the moment. That's my comment. Yeah.
Thank you, Prof. Thank you, Prof. Said. Mr. Azrul, any last thoughts?
Well, I've got to agree with Prof. Said there. I don't agree with those full paying wards myself, because one thing it is intended to do really is to it creates inequity. And if you think about it, it's not just about the same facilities. It's actually the same specialists, the same doctors, the same expertise. So it is essentially meaning that if you are creating that ability to pay, you are actually by paying more, you get faster and quicker access to the healthcare you need. It means depriving somebody of that time slot, because it is taking away from somebody else. And that's where I don't really agree with that approach, and I think it increases inequity more than anything else. But seeing how it's final thoughts, I just wanted to emphasize on the need for us to have a serious grown-up conversation concerning healthcare financing, especially when it comes to Malaysia. We have to look at where we are spending our money, what is the money being spent for, but also look at what we're doing to solve some of the problems that we have in healthcare and whether it's enough. And that starts by acknowledging that we are not doing well when it comes to health. We are actually failing when it comes to healthcare, with so many of the people falling ill with non-communicable diseases, who are falling ill, or being struck by stroke, cardiovascular disease, by cancer, diabetes, chronic kidney disease, kidney failure. The list goes on. It's a crisis that we are currently under, and I feel that the people in authority and our politicians don't act like we are in crisis. They act like it's business as usual, and that somehow, inshallah, God will provide, and the taxes will be sufficient, and we don't need to really deal with health. Health is going to determine the future of this country for the next 10, 15 years. And we need to be able to make sure that we're able to have people in the best state of health so that they can be productive citizens, they're able to contribute to the economy, pay their taxes, and most importantly, not suffer from premature death. And today, more and more people are facing premature death as a reality that they will have to look to. For example, the tobacco bill, I think briefly mentioned by Professor Woody just now, how can we accept that 13,000 people each year are facing premature death due to tobacco and vape-related diseases? How is this acceptable? How is it that we can accept that 200 people die as a result of road traffic accidents each month in this country? Why are we allowing for us to talk about a healthcare system that was great 15 years ago, but still consider that the state of healthcare in the country is still as best as it was 10, 15 years later? Why are we behaving as if reality doesn't touch Malaysia? So we need to have these real and grown-up conversations concerning how do we sustain our healthcare system today with the kind of expectations that the people have. And I throw it back to not just the government, but also to us as people of the country. We also need to take responsibility of our own health to ensure that we are able to be as healthy as we can be and to be able to contribute back into something like national health insurance, so that while we are healthy, we are contributing to the care and treatment of others who are not healthy, who are ill and unwell.
Thank you, Mr. Azrul. I totally agree with your thoughts on that, and I think it is time for us to really not only look at how economy is affecting health, but I think it's also very important to think about how health ultimately will affect the economy also, because a healthy nation is definitely crucial in sustaining, an economy and the economy of a nation. So, I mean, and actually, that was something that would have been nice if we had more time to talk about the consequences of failing at providing universal health care. But unfortunately, time is not permitting for us to continue anymore. So I will have to end the forum now. So thank you again, Prof. Dato and Mr. Azrul, for answering the questions and for the very, very thought-provoking and informative forum. It has been a pleasure to have you with us for the past 2 hours. And this concludes the webinar. Thank you all for attending. We hope you have enjoyed and gained something valuable from this session. I have certainly learned a lot. So thank you again, Prof. Said and Mr. Azrul. For your
Thank you so much.
information, the evaluation link is being shared in the chat box. Once you fill out the evaluation form and submit it, the link for the attendance will appear in the next page. Please fill that out and ensure that you have entered your email and full name correctly, as your certificate of participation will be based on the information you enter there. The attendance link will be closed by 12 p.m. today. Before I bid you goodbye, please enjoy these videos that we have prepared, and do join us for another webinar tomorrow at 9:30 a.m. Thank you again, everyone, and have a good day.
Thank you, everyone. Take care.
Thank you.
You'll see the difference now. If we change it, you'll know how. Nothing ever stays the same. Once you let it change. It's like a family tree. Part of you and part of me. And if we should separate, go your own way, I won't wait.
Bring the funk back. Bring the funk back.